All right. Thank you very much, both of the speakers for, yeah. Oh. Yeah, I think they're going to mic you up again. So now we're going to have half an hour of questions and discussions. There are two mics. One is over there and another one right here. So if you want to ask any questions to the speakers, please line up, and I will be slowly opening up the floor for questions. So maybe while we wait until she gets mic'd up, a quick question for you. It seems in both of your works, you've been using knowledge graphs to kind of add up to the structure of the machine learning model. Can you elaborate a bit on that? How important do you think that is? And, I guess you did ablation studies, and, is that the key to really advance how these models, these complex models, both perform and also are able to explain the dependencies and correlations that you learn?
Of course. I'm often asked this question now, especially in the light of research where we also try to unify KGs with LLMs in some or other way, and I didn't have a chance to briefly mention that. So medical knowledge graphs are exciting for a few different reasons. So A is they come in the form of structured knowledge representations. Sometimes or often they are built from curated biological repositories, so there is at least some line of evidence or provenance where we can take a piece of relationship and then go back and get a sense of what is the specific publication, specific experiment that supports the existence of that relationship. The challenge, however, is that they are generally very difficult to build. It takes lots of time and effort to build the knowledge graph once. It then becomes very challenging to update it over time. In contrast, models like LLMs, and text-based LLMs in particular, they are general encoders of knowledge, but in unstructured manners. They're somewhat easier to update them, but they can still suffer from this catastrophic forgetting problem. But in principle, right, you can just add more data and you will continue training it. But they are often non-factual in some way. So I think the beauty of there are some advantages, disadvantages of both paradigms. So it's an interesting perspective of how to marry both models together, and there is quite a bit of research in that area. For the projects that I discussed today, the knowledge graphs were particularly suitable to tackle these tasks because it allows us to say something about patients that are not directly comparable to each other. And by directly comparable to each other, I mean looking at the direct overlap in genes or looking at direct overlap in phenotypes between those two patients. And if you do so, the overlap is zero. So it's just nothing to be able to say. And so to this indirect line of reasoning, we can look at, well, these two patients do not overlap, but they are in the same local neighborhood of the knowledge graph, right? So they don't have shared genes, but they have mutations in two different genes, but those two genes are members of the same pathway, or those two genes interact. And that is something, that is the kind of useful information that helped some of the model performance in these tasks.
Okay, thank you. I see there are some people lining up for questions, but I do have a quick one for Dr. Goldenberg. So there was a couple of slides where you were mentioning on how you used this idea of the importance of features at t-1 and t, and then the subset of features. So from a machine learning perspective, I saw AKL and information theory concepts, but how do you then go to explain that to clinicians? What was your experience? Do they understand, or do you, I don't want to say hide, but how do you communicate those terms to a clinician so they understand where the model is putting attention or learning more or learning less, and how this relates to interpretability and explainability, basically?
In my experience, clinicians want to understand how the model will work and how to operate it and what is the expected behavior of the model, and that's the explainability that they want. They don't necessarily want the equations, or I have not had clinicians come to me and say, can you please explain Kullback-Leibler diversions to me? I really want to know. So I think it's those who do want, we're happy to explain, but most clinicians that I've worked with, they're really interested in what can this method do for me and what is the expected behavior. And that we can explain quite easily.
And then how do you when are you happy? When they basically feel that the explanation makes sense to them? That's how you usually are able to allow for this model to be deployed? Or is it a conversation? Do they have to see it in fake experiments? How do you manage to actually deploy the model?
I mean, so in a lot of projects that we are working on, explainability is not a requirement.
Okay.
A lot of the clinicians I work with, again, they want to know what to expect, the expected behavior of the model in terms of predicting risk or predicting outcomes, what are the limitations, what kind of patients is likely to predict better or worse. They're not looking for, Shapley lists.
Yeah. All right.
But I think in general, this sort of whole field of explainability and in terms of how to bring any of that into the clinic is quite fun. In fact, you can, I think it should be a discussion. Sort of the model is saying, okay, this was the outcome. We think that there is a change point, and we think that's why the change point happened. And the clinician says, but I perceive that this was within the norm. Oh, why do you think so? And then there is a further explanation. And I think that there's a bit of work in that field, but I don't think it's clinical grade in any way. But that will be the fun part of bringing sort of that area of research really into the clinic, I think.
Okay, thank you. So please go ahead.
Yeah, my name is Mamata Bhatt, and I'm a hepatologist at University Health Network in Toronto, in University of Toronto. So thanks so much for those excellent talks, Anna and Marinka. This is a few questions actually for Marinka. So I was really impressed by your work. So I was wondering, what was the minimum number of patients required per rare condition to enable, say, appropriate training? So that was one question. And then additionally, did you find that, further when you did external validation, that there were some incompletely penetrant conditions, like say disease progression will behave differently in patients depending on, say, clinical and demographic characteristics, as well as incomplete penetrance, especially for these rare conditions. So can you comment a bit on that? And then I also wanted to ask if you were able to identify the ranked features for those predictions, whether they were disease manifestations or clinical, say, features that we're predicting, because I think that would be really helpful for clinicians so that they're able to recognize such conditions in future.
Yeah, thank you for this question. So regarding the first one, how many patients, what's the minimum number of patients per disease that we need in order to make prediction? The answer to that is 0. So but we need a non-zero number of random simulated patients with the disease. And that's something that we have validated quite extensively across, by leveraging these 3 independent cohorts, where the diseases in the UDN are different than diseases in my gene2 cohort, which are different in disease in the Decipher cohort, that were not, actually we did not have access to those cohorts while developing the algorithm. So there was really no information leakage from the design to the development phase. Okay. So from the perspective of training the model, also convincing reviewers that that potentially works. The most challenging part is, how is it possible that you train the model on the simulated patients, and then after not seeing any real-world patient, the model would be able to prioritize genes well? And so the way this is possible is because we have this simulated pipeline that what it does, it takes into consideration known rare disease knowledge from Orphanet, from a related database in Japan, a few other in US. And then there's this process really kind of simulates a rare disease patient by starting from sampling a gene, and then based on known gene-to-gene relationships, gene variant relationships, it would pull in additional genes. Then it will start pulling in phenotypes. Then it will start pulling in some distractor genes and some distractor pathways, phenotypes that do not relate directly to the disease-causing gene that was initially sampled for. And we sample now 42,000 patients like that, and those are patients that the model is trained on. ensure that those 42,000 patients broadly cover all diseases that are rare diseases currently coded in OrphaNet, which then means that once the model is trained, we need 0 examples of real-world patient, examples of real-world patients for a disease in order to be able to rank disease-causing genes. And performance still there is sustained over alternative models. There are other questions here. For example, you could say, well, how many phenotypes do you need per patient in order for the model to work well? In UDN, we had on average 25 phenotypes coded as human phenotype ontology terms for each patient. In a pilot that we're running with Boston Children's Hospital on rare diseases related to epilepsy, the number of phenotypes is much less, on 5 to 7 on average assigned to patient on average per patient. And we were able to run the pilot there. The second question was a really interesting one, which is that of incomplete variable penetrance for some of those rare genetic diseases. It's a great question. We work on a separate project on Parkinson's disease where we are asking these questions of to what extent molecular and cellular determinants can complete incomplete penetrance in Parkinson's disease subtypes. This is really challenging here because we have a handful of patients per disease, and so there are no these internal subtypes or structures that we could meaningfully address at all. The third question was, can you remind me what the third question
around ranked features that are predicting that rare disease diagnosis.
So as Anna has mentioned, there are similarly as explainability models for time series, there are also various explainers that have been developed over the years for explaining models that are trained on graphs or networks. And so we can adopt those. We have implemented a few of them as part of and provide as part of an exploratory tool that is made available to clinicians and clinical researchers here, really, not clinicians in the actual clinic, but researchers who are looking at patient data and often prioritizing genes that they need to understand to some level, because then often that lead to downstream functional studies in animal models to confirm the causal gene. And they are actually interested in looking at explanations from the standpoint of debugging the model, I would almost say, in the sense of, does the model focus and uses some pieces of knowledge that it's so clearly not useful or should not be used, which would indicate that the data is incomplete, not to be trusted there. Perhaps we should skip that prediction at all. So that is generally the use that we found here. Scientists, clinical researchers have appreciated in Shepherd model.
Thank you.
All right, let's go to the next question there.
Okay, so I have several questions for both of you, starting with Marinka. How do you confirm the legitimacy of the generated patients? Like, have there been any discrepancies between the embeddings of the simulated diseases and the actual gene relationships as they've been discovered and researched further? And what do you believe is the optimal performance to put the model in deployment? Because I see that you have gotten much better results than current state-of-the-art models in terms of finding the correct diagnosis within the top K results. But wouldn't that also translate to every single incorrect diagnosis, meaning an entire leg of the diagnosis odyssey that current patients are going through right now? So what is your goal? Do you want to have in the top 1, the top 2, the top 5, in order to bring the model to say, hey, use this model in order to find it, and it would dramatically decrease the amount of diagnostic odysseys you have to do? And do you want to answer those questions before I go to Anna first?
Yes,
then?
that'd be great.
Okay,
I'll try to be short. Yeah, so it's a great question. We have done lots of ablation studies, sensitivity analysis tests, calculating out-of-distribution scores to get a sense of how distributionally different those simulated patients are from actually real-world patients that the model is being evaluated on, and calculate performance as a function of the distance between the real-world patient versus those simulated patients the model has trained on, to get a sense of how well the model can generalize. As you would expect, then the further away from the space of the simulated patients the real-world patient will be found, and the worse is the performance of the model. It's still markedly better than that of existing approaches, but there is considerable amount and opportunities for improvement there. Whether the goal and motivation here is to expand the model to all 7,000 plus rare diseases. Do we have currently evidence to claim that the model can work for 7,000 rare diseases? No. Why not? Because there are more or less no real-world cohorts where you would have one cohort that would cover 7,000 diseases, right? So you can see UDN cohort that we had access to of real-world patients covered roughly 300, 299 diseases, right? So what does that mean for the model for 7,000 minus 299 diseases? It's hard to say. So at this time, it's not something that I would be able to claim performance across the entire range of long-tail distribution of diseases. And that's the reason why we're running pilots across multiple institutions and multiple countries, because there are different types of rare diseases and rare disease patients overrepresented in certain of those populations, which allow us then to expand the number of diseases that the model is tested on. And because it's so easy to share, that's something that we can quite easily do by adding an additional site.
All right, thank you. As for you, Anna, what was the process like when it came to revising the model from switching variables and outputs quickly when you found out that the cardiac arrest model was not going up to plan due to different complications? Like, did you have to have a discussion with with the CFO that you're switching bases? Did you have to talk with multiple clinicians to say, oh, we have to quickly change the model? What was the process like for you?
I mean, this was all pre-deployment, so we were at the point of testing, actually running tests. We did run some simulation tests with the clinicians of the model using the interface that I have briefly shown, and we just kept asking to derive more and more data from the current database and just keep training, and then in the process realizing that maybe something is off with the calibration, let's dig further, and that's how we sort of said, okay, one step back, we need to redefine the labels. And I think Ismail Akruf, who is the ML scientist, he basically has been in communication with the nurse who works at ICU at all times to jointly do that together. So him finding out that the performance was not as expected, and then working with her to redefine the labels. So that's where we are now. You don't have to talk to CFO about every single model we are working on. That's why there is such a rigorous sort of deployment pipeline process.
How long did that take?
It's still ongoing. The redefinition and collection of the labels that are now using the new definition, that's still ongoing. The process of sort of switching, that was a matter of a month, I would say.
All right, thank you very much.
Yeah.
Thank you. So we'll do a question from here.
Sure. Thank you very much for the nice talks. So I also had two quick clarification questions. I understand probably you have cited some of the studies, and probably I can look them up, but since you were here, I thought probably it's better to ask for those clarifications. So specifically for Dr. Goldenberg, so in terms of deployment, obviously the problem you touched on is a very challenging problem, the problem of deteriorating the performance of the model as you deploy it in the real practice, right? So, and I understood that some of the methods you described, that how you would address that, I followed some of the ideas, like you would have a separate validation data to just prevent that. If you could elaborate a little bit further, high level, how would that be achieved? And another very quick clarification question for Dr. Zitnik. So in terms of the knowledge graph, so I mean, when we talk about knowledge graph in the biomedicine, there's probably ocean of the data that you can use to train those KGs. Especially when it comes to genetic data. I was just really curious, what did you use to train to just build the knowledge graph itself? Did it include, for example, EHRs, publications, PubMed, stuff like that? So yeah.
Okay. So one of the things that we have for the models that I actually in silent trial running on their own and retraining every night. So there are such models for emergency department that I didn't talk about, but those we basically pretty much retrain every night using the past year of data. I think the regularization everybody always uses is just a question of how to figure out what is the effect and what regularization is most helpful to deteriorate. So it's not entirely part of the pipeline, so this was more of a research project, but we have, we're doing sort of the simulations. We've done the simulations for that project where this is the expected rate of deterioration, and then looking at what are the likely parameters, thresholds and things that we need to update going forward based on our assumptions about how the model will deteriorate, and then using that. We have used the feedback loop actually in collaboration with Mohammed, who talked about the chart watch. So we used some of the ideas of the feedback loop on the chart watch that is currently running. And so first, you have to evaluate whether deterioration is actually happening. And so in that particular case, we didn't detect significant deterioration. So that's another thing that we can actually do with the running models, the models that are already deployed.
Okay, thank you.
But a lot of counterfactuals sort of simulated performance based on the assumptions about how it's the worst case scenario, how it could deteriorate.
Thanks.
Yeah, regarding the knowledge graph construction, PRIME-KG is constructed based on knowledge repositories. So for clean genetic data, the primary resources are CleanVar with information on pathogenicity or likely pathogenic variants, and then OrphaNet for the broad coverage of rare diseases, and then a version of OrphaNet that exists for that's built in Japan, and some internal data from not internal data. Yeah, that's the genetic. These are the genetic resources for the PRIME-KG knowledge graph construction. What we have now currently in the works is really we moved much more towards this notion of unifying LLMs with KGs or use them both in some productive manner. So our current approach, which is a follow-up to THGNN that is in the works, is an agent-based system that uses that accesses the knowledge graph through a form of RAG system, and then accesses APIs from FDA directly. So then we have an LLM that can, when it's asked by user a specific query, that LLM knows how to use tools, and it can go on the fly and retrieve the latest data by having access to around 100 APIs from open targets, which has very rich information about associations, including genetic, between genes and diseases, and then roughly 100 APIs, distinct API endpoints from FDA that includes entire FDA regulatory documents for all approved drugs from 1939. And this allows us to really move forward beyond what THGNN has been able to do. Specifically, being able to identify patient subpopulations or patient groups and match them to therapies in a more precise way than what we can do now. And then also not be necessarily limited only to curated biological repositories and data that comes from them, which we all know that, well, there is some delay and there might be strong areas of incompleteness because there are various biases going from funding to investigational biases in terms of what goes into some of the curated databases. And there might be some useful information in scientific literature, but how to decide what is useful and not. And so we're seeing that this type of compound systems that can be developed that marry a free-form scientific literature information with curated factual knowledge for grounding those models can be helpful to further improve the model performance. There are also opportunities. I think there's a very nice tool called GraphRag that Microsoft Research recently put out, where you can think of using those models to improve or build or refine the knowledge graph over time, or to contextualize it to certain patient populations or certain countries if you are working on international systems, and that's something that we're exploring as well.
All right, we have 5 more minutes, so let's go with the question.
I'll make
there
it quick.
and see.
Hi, my name is Sage Rutherford. I'm a PhD student in the Netherlands. Thank you both for the inspiring talks. My question is for Anna, and it was related to how you define trust. I really liked the slide where you sort of presented, I think, like, 10% trust, 20% or whatever, but it's often like a yes/no question. But in my experience, trust is something that's built up over time and experience. So I was just wondering if you could comment on how you define trusting a model.
Yeah, in this case, we simply said trust is as a proportion of the number of positives that we are accepting. Some of them are false positives, some of them are true positives, and 100% trust, obviously, we are going with all of the positives that we are accepting, and then percentage of that, right, 50%, and then you take 50% at random, and you sort of say, okay, we have 50% of trust towards the model. It's just a simple definition. I like the idea to simulate a more complex model where trust changes over time and how that affects the model. I think that's something that you can also simulate, but then you have to make further assumptions about, what is the rate of the trust change and such.
And just a small follow-up. What level do you think you should model trust? Like, is it a per clinician, per system? Like,
I think in our case, we were looking at sort of assuming there is a 50% trust to the model to generate the labels. It could be one clinician, it could be a set of clinicians. It's really about how the labels are generated in the end that are being reused to, well, not reused, but that are being used to further retrain the model. So that's dependent basically on the errors and the flipping and the labels that we are looking for. So could be, you could define other metrics per patient, per clinician if you were interested in, and also further simulate that different clinicians provide different trust, and so then there will be a bias in sort of error and label flipping.
thank you.
Yeah.
All right. That was quick, so let's try to have one more squeeze.
Thank you both so much for your wonderful talks. My name's Albert Young. I'm a dermatology resident at Henry Ford in Detroit. And my question's for Dr. Zitnik. I think you've answered a lot of it already. But basically, recently, I met a patient who was on a diagnostic odyssey. And I ended up diagnosing her with the 5th ever reported case of a rare condition after spending an evening kind of Googling for terms related to her phenotype. And that was through reading like a black and white case report from Norway back in the 90s. Like, is that information being captured in your knowledge graph? Is this a tool that I can use for other patients that I have suspected rare conditions for?
Yes, a great question. So whether you can use this tool, yes, you can use this tool. We have it publicly available, and also if you follow up with me over email, I'd be happy to kind of point you directly on how you can just use it practically. We even have a Hugging Face space where you can just upload or describe your information, not patient-identified information, like set of phenotypes or variants, if that's something you feel comfortable with, and kind of run the model there without any local installation. Regarding that specific case, impossible to say, but if that specific publication that might be somewhat obscure from the general scientific literature would currently be included in Orphanet or related databases, it would be in our knowledge graph. Otherwise, likely not, and that is one of the reasons why we are motivated by more of these compound systems that can then use APIs, such as API to the NCBI system, to then retrieve literature, including patient cases that are there's so many of them, they're not often necessarily cited particularly well, and so they're difficult and challenging to find. And so then the approach is that we have an LLM runs that goes through, uses API calls to retrieve publications that we then map onto the Shepherd knowledge graph and try to resolve some of the entities and use those for reasoning as well. This is not implemented in the current version of Shepherd. It's an ongoing project that we have.
That's remarkable. Thank you so much.
Okay, it seems there are more questions, and we have a couple of minutes, so please, if you can ask.
Hi, I'm Sandeep with DLA Piper, one of the sponsors for the event. I have a quick question. How do you deal with, what are the limitations you found with synthetic data?
There's so many. So yes, it's an initial solution or try. But I would really encourage those who are interested in this area to think more carefully about them. So one key limitation is that this problem is that there's no magic to it, right? So just expecting that we'll be able to extrapolate to the very far rare disease that none of its related, somewhat related, or even indirectly associated rare diseases are in knowledge curated databases, ClinVar, Orphanet, and related, becomes very it just doesn't mean that simulated patients for those diseases will work particularly well. So the coverage of diseases was one of the big concerns and consideration for us. So if we generate now 42,000, or like we can generate more and more patients, does generating more patients help us increase the number of diseases that we cover at meaningful accuracy, so that we can use, we expand the applicability, the scope of the model towards a larger number of diseases. We have done our best, given the current sizes of this, of ORPHANET, ClinVar, that are the primary resource, and human phenotype ontology that are primary resources of the data to generate simulated patients, but much more could be done. I think that a nice opportunity here would be to also couple these type of models to large EHR systems and healthcare databases, even if they might contain common patients, and capture additional dependencies between diseases and some of the molecular data when the data set cohorts come in the form of matched clinical genetic cohorts. This is something that we have not done in the initial project of Shepherd. The advantage of that is the model is easily shareable, but I would expect that we could increase the disease coverage by considering expanding the data generation pipeline to also include EHRs in addition to these generating patients based on known variant, gene pathway, phenotype relationships in scientific literature.
Thank you.
All right, so I know there is a quick question maybe, but very quick, please.
Very quickly, okay. I'm Luca Foschini. I'm the president of Sage Bionetworks. We are a Seattle-based nonprofit advocating for open and collaborative practices in the biomedical sciences. One question I had is around synthetic data and the possibility to release it like fully in the open. Genetic data most of the time has to have restricted access because germline data has high risk or re-identifiability, but you're generating synthetic data there. Sometimes that could still be identifiable. How are you thinking about that, and how can you make it as available as possible? Thank you.
Yeah, that's a great question. For the synthetic data generation process, the pipeline is publicly available. The resources that we use to generate those patients are also very linked, easily linked. So one can get then controlled access to ClinVar or other resources and generate those patients internally, or if the privacy would be an issue. Another point here is that there's always this problem, and it's been shown that through membership attacks, it's possible to elicit the training data point that the model was trained on, even if the only thing you release is a trained model, right? And that has been shown that LLMs, some of these larger models suffers, and I expect, or I have no proof to offer that why knowledge graph models would not suffer from such a problem. So what we are thinking about is really also summarizing data and working with summarized aggregate level statistics. That's something that we are considering in a collaborative project that we have with Department of Veterans Affairs, working with Tianxi Kai from Harvard Medical School that has built these large concurrence matrices that contain information about how often two medical concepts co-occur in an EHR record of one person. And then generating those statistics at the summary aggregate level that then could be used as input to train those models without revealing a patient identity, provably. So that's something that we are considering as well.
Thank you.
All right, so with this, let's thank the speakers for their talk and their answer to the questions.